Dear friends, my name is Danny Buser from the University of Bern, and I had the pleasure to participate as a speaker in a webinar CE course organized by Harvard School of Dental Medicine. The host was Professor Gallucci, and I was sharing the virtual podium with my dear friend Mauricio Araujo. Based on multiple requests, we have now organized the video clip of this webinar and put it together. That includes not only the two presentations, but also then the discussion, which was most interesting. The topic of this webinar was implant placement post-extraction in the aesthetic zone, which is a very challenging clinical condition for involved clinicians. The questions are: do you understand the tissue biology that will influence the treatment outcomes? Do you know the selection criteria to select the appropriate treatment option? All these aspects have been discussed during this 1 hour CE course, and you can look forward to a lot of information. I pass on now the word to Professor Gallucci, who will be the moderator of this session. Herman, please take over.
That I am very thrilled to introduce to you today. First, I would like Professor Daniel Buser to say hi to all of you. As you know, by his impressive trajectory in the field of implant dentistry, he has moved, taught, and created the field that we all now use in our clinic. So, Danny, thank you very much for joining us today.
It's my big pleasure.
And also another colleague that needs no introduction, but I will do one. If you, as I said, if you read dental literature and implants and you haven't heard his name, it's probably that you need to be reading a little bit more, because he's everywhere. So it is my distinct pleasure to introduce Professor Mauricio Araujo from Brazil. Mauricio, welcome to the webinar.
Thank you, Jim. The pleasure is all mine. Good morning.
All right. So this is how the dynamic of the webinar will be. The panelist will address the topic of implant placement, post-extraction in the aesthetic zone. And then at the end, we will do a Q&A question. I would ask all the participants to use the Q&A question that you have as a function in this Zoom webinar. And then at the end, the panelists will take the questions and answer them. And without further ado, I would like to give the screen to Professor Daniel Buser to start with the webinar today. Danny, the screen is yours.
Yeah, thank you very much, Herman. It's a big pleasure to be back. I'm not back in Boston. As you know, I spent twice a sabbatical at Harvard in the early days, and not too long ago, 4 years ago in 2016, has been a huge pleasure for me to go back to my second hometown, Boston. And the topic today, of course, is an extremely interesting topic, because when you are in daily practice, you're gonna think about that every single case when you see an implant patient. So post-extraction implant placement, we're gonna limit to aesthetic zone, primarily single tooth, to really focus within an hour or so. I hope that my forwarding functions. We'll see. We have 3 topics. I give a short introduction, and then of course Mauricio will talk about ridge alterations post-extraction, what happens when you do socket grafting, then ridge preservation followed by implant placement later on, and also about immediate implant placement. And then in my second lecture, I'm going to talk about then the concept of early implant placement, which is another alternative. the advantages, how it's done, and at the end we're going to have conclusions and of course a Q&A. So Herman, you tell me when the screen is moving, because we had a problem before when we did a try run. So
it's all perfect, Danny.
Good. So post-extraction placement is a very frequent indication. In my practice, about 70% of implants are post-extraction. That means the tooth needs to be extracted first, and then we do the implant treatment. Very demanding in the aesthetic zone, and what we learned is that timing is extremely crucial for the outcome. And that's a very important point to understand. And when you look at these cases, then you see that we have 5 cases with an extraction. And when you look at the cone beams, you see all of them are different. And it's very important to understand that when you do these cases, that every case is different. And of course, the logic of thinking means you cannot apply to every case the same treatment modality. You need to pick the treatment modality gives you the best chances for successful outcomes. Okay, what we learned in the last almost 30 years in the aesthetic zone, to get a really good aesthetic result, you need the buccal bone wall. That means when you do a treatment, you must have, at completion of healing, an intact buccal bone wall to support your soft tissues. It's the thickness and the height. Where is the peak of the buccal wall? That will really determine if you have a good aesthetic outcome. Besides that, of course, the position is important, the appropriate implant is important, and you also should have a good keratinized mucosa, but in the aesthetic zone, that is not of primary concern most often. And you see what we learned, you see the third point, to have the implant fully embedded in bone. This is really most critical when you are driving to get excellent long-term results. Now, here you see 4 cases I treated all together with Professor Belzer, you see, and you can see that we have achieved a very nice long-term outcome, and you can see that here the facial bone wall obviously had been reinstalled or regenerated. Patient needs to have a good home care for sure as well, and then you can go up to 25 years. These are the longest cases we have. Soon we're gonna get into 30 years. I'm absolutely convinced when I turn 80, I'm gonna have patients with 40, 45 years of follow-up documentation. Now, when we moved into the aesthetic zone and in a post-extraction placement, early 2000, millennium change, we have seen dramatic complications with immediate implants. And we did not understand why we have these kind of problems. And we learned then with time that implants in a facial malposition can be a problem, to use oversized implants can be a problem, or that the bone resorbs post-implant placement, or thin mucosal biotype. These are all risk factors for these kind of complications. ITI addressed them very nicely, and this is a great success story of the ITI, because at multiple consensus conferences, we addressed the topic of implant placement post-extraction. In the first one in 2003 in Gstaad, we defined the timing and the terminology. So type 1, 2, 3, 4. And we also decided to use the terms immediate placement, of course, has been established at that time, late placement for 6 months and longer. And in between, we agreed in the group to use the term early implant placement. And here you see the consensus conferences we have had in Gstaad 2003, Stuttgart, Germany 2008, Bern in my hometown 2013, and most recently 2018 in Amsterdam. You see the paper by Gallucci where we combined then the placement protocols with the loading protocols. Okay, what we learned in the early phase of this development, of this success story of ITI, was that when you have an extraction, you see some changes. And you see when I open up, this is a case 8 weeks post-extraction, you see here that the facial bone wall is resorbed. It's a crater-like defect. And in the year 2000, we did not understand anything. And actually the eye opener was then a study by our friend from Brazil, you see, Mauricio Araujo, and that will be now his lecture. He will start with that. You see this bundle bone resorption. You see a fantastic paper. I think the best paper concerning citations, 100 citations a year, which is for a dental paper enormous. And I'm very happy that Mauricio has done all these studies in 2004, 5, 6, many. And he will now take over and talk about these aspects, you see, about socket grafting, then ridge preservation and late placement or immediate implant placement and internal grafting. So these will be very interesting topics, and I hand over to Mauricio for his presentation.
Now, thank you very much, Professor Buser, for the wonderful introduction. It was great. It will make my job very simple. Now I will move quickly to my presentation. So greetings from my university in the middle of South America. And I will move quickly to continue Professor Buser's presentation. Now, let's look at the alveolar socket as a bone defect. Well, it's a very nice bone defect. It has 4 walls, meaning that the wound stability is maximum. Not only that, I have a plenty of availability of bone cells to migrate into the wound. And of course, I have also plenty of blood supply. Now, this very nice bone defect may seem to be the perfect bone defect. However, the walls of such a bone defect, they are very special walls. They are very thin and they are made by a very
Mauricio, if I may interrupt, you need to share your screen. Complete the share of the screen. Yeah. Sorry for the interruption.
No. Is it okay now? Can you see now?
We are fine now, Mauricio. Yeah, so you can start the presentation.
No, it's fine. I was not working properly. Okay. Now I think I should start over. So I was saying that we can look at the alveolar socket as a bone defect. And this is a very special bone defect because it has 4 walls, meaning that the wound stability is maximum, the availability of bone cells to migrate into the wound as well, it's the best possible, and the blood supply. However, when the socket healing takes place, this very nice bone defect, although it seems to be perfect, it will change dramatically. So let me explain why the dimension of the alveolar socket changed so much during socket healing process. Now, this is the socket healing that can be divided in 3 phases. To your left of your screen, you see the first phase that's called inflammation. So immediately from extraction, the socket is filled with blood. And after a few days, this blood receives the migration of inflammatory cells that will cleanse the area. Following that, we have tissue formation, new tissue formation. And the first tissue to be formed is the connective tissue that will be the organic matrix for the mineralization and to form a bone that's called woven bone. Why it's called woven bone? Because the organic matrix has collagen fibers that are organized in a woven manner. Okay, this is very nice because the woven bone can be formed rather quickly. So in few weeks, the entire socket is filled with this type of bone. But this type of bone is very soft. It has no load-bearing capacity. So it has to be removed by osteoclasts that will remove this woven bone. However, the woven bone that was formed and removed by the osteoclast to open space for lamellar bone formation and bone marrow, also remove the socket walls. So you can see in this buccolingual section to your left, you see higher magnification, the lingual crest that is covered by these black balls. These black balls are osteoclast. And you see the same to your right. You can see at the buccal crest, these black balls that are osteoclast that are resolving the buccal crest and then reducing the buccal crest. So the osteoclast, they reduce the socket walls as well. They remove the woven bone. But what happened is the following. When the osteoclast removes the buccal wall, it exposes the woven bone. And woven bone has no loading bearing capacity and cannot resist to the pressure of the soft tissues. So you have by that the reduction of not only the original buccal wall, but also the reduction of the woven bone that was formed in the entire space of the previous socket. So by that, the entire alveolar process is reduced. Now, that's fine. Now, the reduction of the alveolar process may cause problems if you want to place an implant. Therefore, the concept of preserving the volume of the alveolar process is very interesting. But we have to pay attention that ridge preservation to preserve this dimension only makes sense if when patient comes, I analyze in a CBCT scan the alveolar process, the anatomy, and come to the conclusion that this anatomy, if preserves, can house properly an implant. So I have 4 different cases here. Obviously, case 1 and 3, if I preserve successfully the anatomy of this alveolar process and this basal bone, can house an implant. But patient 2 and 4 obviously should not go for ridge preservation because it doesn't seem a nice idea to preserve this anatomy. If I preserve the anatomy of number 2 and number 4, I cannot place an implant. So that must go for ridge augmentation. Now, let's preserve the ridge. And the ridge preservation can go either to late implant placement or can go to immediate implant placement. Now, let's imagine that I go for late implant placement. Here you can see a case in which I'm going to preserve the ridge by doing a socket graft. A socket graft with a biomaterial that should act as a permanent scaffold for the host bone. Just like titanium is a permanent scaffold for the root. That is the concept. So I place such a biomaterial and 4 months later, I reopen and do and perform my late implant placement. Great. Now, from time to time, we can also do ridge preservation. And if you feel that your case has a very high stat demand, you can use a soft tissue graft. So that is a case like that. You can follow a tooth extraction. I'm performing my socket graft with a slow resorbing biomaterial. I wait 4 months. I come back to the implant site, to the edentulous ridge, open the flap. I place my implant. You can see I have 2 millimeters of buccal wall. This is not the problem, but for aesthetic purpose, I may want to place a connective tissue graft. And you can see to your right, this is after 2 months, and I can start my placing of my final crown. So ridge preservation plus late implant placement. Now, finally, I can also do ridge preservation if there is a lack of buccal wall. But when there is a lack of buccal wall, you need to compensate the lack of a buccal wall by placing a collagen barrier. Okay. And by the way, here you can see that I had opened a flap. However, I tell you, you don't need to open a flap to place a collagen membrane. You can do that through a tunneling technique. But of course, you can, as always, after 4 months, you place an implant and you have preserved the ridge. You can see in the CBCT scan, the very radial pack area is the place that I had preserved. Fine. Now, there are a lot of histological data showing that it works, and of course, many clinical studies. In the literature, there are 25 systematic reviews that shows that ridge preservation works. It shows that decreases to 55 to 100% the need for further treatment. And that variation, it's because there are several ways of preserving the ridge, but I'm showing you the one, the socket graft with a biomaterial that is low resorbent as being the best, the most predictable. All this literature also shows that the aesthetic outcome is very good, and all ridge preservation techniques, they are effective to reducing ridge resorption. That's fine. But now I'd like to move my presentation for ridge preservation, not for late implant placement, but now I want to discuss ridge preservation for immediate implant placement. Now it's a little bit different. I have much less recipient bed. Here, when I do ridge preservation for late implant placement, I have a very large recipient bed with a lot of blood supply, with a lot of availability of bone cells to migrate. And of course, I have more bone biomaterial. But now when I place my implant immediately, everything's reduced. And I want to study, to evaluate with such technique, with such a way of doing ridge preservation, I can really preserve the ridge, and how much I can preserve the ridge. Now, together with Dr. Bob Levine from Philadelphia and his research group, I have performed several studies. I'm intend now to present 2 of them, but there are much more and a lot of data. But because of the constriction of time, we have a reduced time, I like to present some of this data. Now, in this data, I'm trying to evaluate ridge preservation with immediate implant placement, and I will specifically evaluate the anatomy of the alveolar socket after the implant placement. For that reason, we identified 41 patients that received 50 implants at the maxilla central incisors. The surgery that was performed is what you can see to the right of your screen. Minimally invasive tooth extraction, placement of the implant, then a connective tissue graft was placed in some of the cases, and then socket graft in the gap and sutures. And after the healing, you can see some of the cases. However, all these patients, they were subdivided in 2 groups. A group in which the gap that was obtained following implant installation was larger than 2 millimeters. And patients that the gap following tooth installation was 2 millimeters or narrower. And then these patients were evaluated after average time of 5 years. Now, let me show you the CBTC scans. To your left, you see patients representing the group with the wide gap, and to your right, you can see patients represent the group of a narrow gap, 2 millimeters or less. Now you can see the first group of results. The first column, you can identify the buccal and palatal bone in this table. The second column in this table represents the level in which I had measured the thickness of the buccal wall. 0, meaning that the implant shoulder, 2, meaning 2 millimeters below the implant shoulder, 4 millimeters below the implant shoulder, and 6 millimeters below the implant shoulder. Now, the third column and the fourth column represents the corresponding values of the thickness of the buccal wall and palatal wall at both wide gap group and the narrow group. And you can see at the buccal bone, at the buccal aspect of the implant, where I had placed my implant with a very wide gap, I have a 2 times the thickness of the buccal bone that I could identify in the narrow group. And this difference was highly significant. So much more bone in the wide narrow gap, in the wide gap group. Now, if you subdivide these 2 groups according to the presence of a connective tissue graft, you can see that the best outcome, the best possible outcome is achieved when I combine a wide gap with the placement of a connective tissue graft. Thus, wide buccal gaps, more than 2 millimeters, graft with an organic bovine bone, following immediate implant placement promotes a better ridge preservation than otherwise. Now, let's follow, and I will do the ultimate comparison. I'm going to compare the implant site with the corresponding pristine health contralateral incisor. So I'm identifying 25 patients and I'm placing 27 patients with 27 implants at the maxilla central incisors, and I will compare with the contralateral health central incisor. Now, the technique was the same as described before, and the reevaluation was in every 6 years. Now, this is the design of the study. I'm comparing my health maxillary central incisor with the implant site. So a pristine site and implant site, and I compare both groups. Now, that's very fine. Let's see what happens. Here to your left, you can see CT scans representing patients in the wide gap group, and to your right, you can see patients representing the narrow gap group. Now, let me show you the results. This table represents the results of the reduction in percentage. The comparison between the width of the pristine site with now my implant site, how much it has reduced in horizontal direction. So 1 millimeter below the bone crest, at the wide group, I had a reduction of 50%, while at the narrow group, the reduction was 76%. And let me remind you that the implant shoulder is not at the buccal crest level, it's below the buccal crest level. Now, when you move 3 millimeters below the buccal crest, you have a reduction of 7% at the wide group, and in the narrow group, the reduction was 55%. And 5 millimeters below the crest, the reduction in the wide gap group was only about 1%. And in the narrow group was about 40%. And this is very different. Now, let's talk about the thickness of the buccal wall at the pristine site before tooth extraction and at the implant site after the healing of the ridge preservation and the implant placement. Now you can see here 2 sites at the wide group gap and in the narrow group gap. You see the thickness of the buccal wall was similar in both groups. However, following my implant placement and ridge preservation, I could see that in the places in which I was able to have a wide gap, I had a very thick buccal wall, about 2 millimeters of thickness. Whereas in sites in which the gap was very narrow, the thickness of a buccal wall after the healing of the implant was about 0.5 millimeter. Now let's talk about the height of the buccal wall. Now you can see in this particular table, the height of the buccal wall and the height of the palatal wall. Here you can see two sides, the height in both groups was the same. However, following the healing of the implant placement, you can see a striking difference between the height of the sites in which I have a wide gap and the sites in which I had a narrow gap. Finally, I'd like to describe to you the reduction in terms of cross-section area. You can see that I have divided the area in 3/3, the coronal, middle, and apical thirds. And you can see in all these thirds, the reduction was much more marked, much more reduction in the narrow gap group. Now, you can see in total to your right, the total reduction in the sites in which I had placed my implant with a wide gap. I had about 10% of reduction, while in the sites in which the gap was narrow, the reduction was about 43%. Thus, in conclusion, wide buccal gaps grafted with anorganic bovine bone following immediate implant placement preserve more than 90% of the alveolar ridge dimension. Thus, as overall conclusion, ridge preservation followed by both late and immediate implant placement can successfully preserve the dimension of the alveolar ridge. However, to achieve this, we have to check the morphology of the alveolar process or the morphology of the gap following implant placement. With that, I finish here my presentation and give the stage to Professor Buser.
Excellent. Interesting studies. I think we're going to have a lot of time also to discuss them. Do you see my screen back? Is it okay?
Yep. All perfect, Danny.
Yes, okay. I want to mention, if some of you want to have a handout of my presentation, then you are always welcome to do so. So you can send an email to handout@burn-co.com, and then we're going to send it to you next Monday or Tuesday. Okay, before I move now to my topic, I want to show you, I have been, of course, well known that I'm completely opposing immediate implant placement, as long as we have had so many complications seen in the field. But then, as I said, I developed the risk factors and then the recommendations, inclusion criteria. And after my sabbatical in Boston, learning a lot about digital technology, then when I was back, we started to do immediate implant placement in well-selected cases. I want to show you only one. It's only done when there is a fully intact facial bone wall, and we only do it in thick wall phenotypes. And that will be discussion then we can have with Mauricio. And then we do it always computer-assisted, flapless. And whenever possible, an immediate restoration. This is a typical case. Most of the cases I have done, about 20, have been done in the first premolar or second premolar sites, a few in central incisor sites. But there you don't find a lot of thick buccal walls, and you see here the whole planning and so on. And of course, this is always done in close collaboration with the pros department, in this case, Samir Abuayash. And then the surgery, extraction, immediate placement, everything prepared, the crown prepared, a CAD-CAM crown, you see acrylic, and here you see then out of occlusion. Samir did a great job. You see the implants are rather deeply placed to compensate some of the remodeling. I'm anxiously waiting from Straumann to get a hybrid design, a BLX implant, or the BLT, because then we have there in the crest area, in the neck area, a machine surface. But I have to tell you, these 20 cases, I'm very pleased what I have seen. Although very strict in the moment, about 5–7% of the cases we are doing are done immediately. And I'm sure we're going to expand slowly the percentage of this one. Okay, now the lecture on early implant placement. You see, this is the window 4 to 8 weeks post-extraction as defined by ITI in 2003. You see, we do it when there is a thin wall or a no wall, because we have extraction cases where the wall is already resorbed, fractured roots, whatever. You need enough bone, palatal, apically to stabilize an implant when you put the implant in. That's very important. And then we get most often a two-wall defect to rebuild then the bone with contour augmentation. The paper that described this technique has been published in 2008 together with Dr. Chen and H.B. Weber and Urs Belzer. I show you a case, 73-year-old lady. She had an implant treatment in the mandible by me 10 years earlier. So she comes back and the referring dentist said, this crown is coming off all the time and can you place an implant? So she only worried about the single tooth situation of the canine. You see excellent volume of bone, but no facial bone wall at all. And here you see then the extraction. That's a big advantage of early placement, because then you get soft tissue formed, you get more keratinized mucosa, you get all the bundle bone resolved, what Mauricio described so nicely, and what you also get, you see, you get a spontaneous soft tissue thickening into the socket, because you get there first soft tissue formation. And I'll see if it works. I want to show you how this is done. Extraction is done flapless, very important. And you take it off very carefully. And what you also see then in the second movie on the bottom right, you see this bundle bone resorption, resorbing the buccal wall, and you see the ingrowth of soft tissues. I hope that you can see everything, because that didn't work in our first test an hour ago with Brazil. Okay, you see how the buccal wall resorbs, you see the flattening just in the middle of the socket, but you see you get much more soft tissue. So in a case like this, when you know I place my implant 4, 6, or 8 weeks later, no socket grafting, please. Allow the soft tissue to grow in, because then you have a perfect chance that there is no need for any connective tissue grafting later on. And this has been very well documented in a paper in the Journal of Dental Research with Vivian Chapuis, published 2015. You could see that the thickness of the soft tissues increased from 1 millimeter on average to about 5 millimeters. Okay, then after 4, 6, or 8 weeks, the central incisor most often 6 or 8 weeks. Then we're gonna do an open flap procedure. That's a disadvantage of early placement. You need an open flap to rebuild that bone. You cannot do that flapless. And we use today a large flap with a triangular flap, because then we don't have a releasing incision within the aesthetic zone. We move the releasing incision distal to the canine or even to the first premolar. And here you see this lady again, the mid-crestal incision slightly palatal to pick up the soft tissue, and then the releasing incision. And you see beautifully, you see this triangular flap, and you see, of course, immediately this big bone defect, but only in the middle. The ridge width, mesially and distally, has not changed within 4, 6, or 8 weeks of healing, as shown in a study by Vivian. And then we do, as first, blood collection, and we harvest autogenous bone chips in the vicinity. So we do in the same flap, we take the autogenous bone chips, very important, to speed up later on then the formation of bone. Here you see the local harvesting. You need a sharp bone scraper. You can reuse this bone scraper. These are hoof 3D bone scrapers. And these bone chips go into a mixture of blood and ringer solution. Also natrium chloride, And then there, as we have learned, and I will show you, they immediately release growth factors. So here now you see the bone chips in this blood bath, you could call it. It will not coagulate there. We continue implant preparation, 15, 20 minutes later. Now we take this solution, we call it bone conditioned medium, filled up, you see, rich of growth factors, primarily TGF-beta1, and we use it now to activate the second bone filler called VBBM or BioOS, and you transfer the growth factors to the second bone filler. So this has been very well documented in vitro studies. The lead has been here with Reinhard Gruber, who is now back professor in Vienna. And now lately you see that the new head of our cell biology lab is now Maria Asparuova. And here you see the latest publication that presented the data from mini pig bone chips. You see with Ringer solution or a combination of blood serum and Ringer solution. I don't want to go into the details. There are two main growth factors that really are released by the bone chips. This is TGF-beta1, and the second one, a little bit delayed, is BMP2. Both are potent growth factors in the field of osteogenesis, and here you see how these functions. They have an interplay. I'm not a cell biologist, but it's amazing to see what works then in the histology. You see the TGF-beta1 is a well-known proliferation factor, whereas then the BMP2 is a differentiation factor and also influencing the mineralization of the early bone formation we have. And that explains a lot our excellent findings from in vivo animal studies, because two of the papers with Simon Jensen, he's back in Copenhagen now, they show beautifully the osteogenic potential of autogenous bone chips. And you see that here, you see the yellow or the green circles, always ahead of the whole competitors, whereas the study also showed that one filler showed an excellent volume stability, which is VBBM or BioOS. So therefore, we learned early on the combination of both two fillers combined, we call it a composite graft, really maximizes then the effect. And you see from these studies here, one is a 4-week specimen that was done with Professor Schenk, and the other was a 2-week specimen that is with Simon Jensen. And you see an amazing amount of woven bone formation, even at 2 weeks of healing, this Jensen 2006 paper. So if you want to really maximize bone augmentation or bone formation early on, you need autogenous bone. Now I show you how this is done in that patient. The lady got the implant inserted. We have to go for a correct 3-dimensional positioning. We know this concept of comfort zones. And you see apicopalatally, you see orofacially, of course mesiodistally, axis must be correct. The paper referred to is this ITI paper from 2003, published 2004, high flyer citation paper, more than 500 citations, an ITI consensus paper. And then when the implant is placed, it's about 3 millimeters below the future mucosal margin. Then we have to be palatally below the crest. And then we use a 2 millimeter healing cap to rebuild the bone. Then to get then the peak of this facial bone when it's regenerated, coronal to the implant shoulder. That is the whole concept of this technique. You see the two-wall defect, the exposed implant surfaces inside the bone. In borderline cases, you can minimize, take a narrow diameter implant to optimize this. But when you have a canine, normally we can place a standard diameter 4 millimeter implant. So this is the contour augmentation technique, 2-layer composite graft, autogenous bone inside, DBBM outside, collagen membrane to cover it up, primary closure. This technique is more than 20 years old and has been very well documented. You see here then the two layers, autogenous bone on the left side, DBBM on the right side. And here you see now from an animation video with PerioPixel how this is done. I did that during my time at Harvard. 2016, a time-consuming project, I have to tell you. So this is autogenous bone first, then DBBM second. You do the contour augmentation, you over contour. So I want to have on top of that then a thick regenerated bone. So then the membrane is cut into 2 pieces, and then you see, you trim it so it will fit well. And you see here that the membrane is rather stiff to begin with. Then you put it in place, and then you start to soak it with BCM blood, and then the membrane becomes very easy, adaptable and adhesive. And then you see with the instruments, you actually put it in place. In a case like this, there's no need for fixation tags or pins. We use these tags in about 5%, but predominantly in the mandible, where the anatomy is much more difficult for this filler application. On top of that one, we go for a primary closure, and then we have a very nice situation. Here you see the patient, again, you see the 2 layers of membranes, then at the primary closure. We go for 8 weeks of healing since 2008. That's a long time. We are using 8 weeks of healing. And then we do just a punch to reopen, to have access to take the small healing cap off, put the longer one in. Patient went back to the referring dentist. She got immediately, straight away, the final restoration. She didn't want to have a provisional. She didn't care about the recessions, the mild recession at neighboring teeth. And here you see the patient 3.5 years later with this implant crown, implant well integrated, and look how well this facial bone wall has regenerated in a patient with an age 73. So that is what we try to achieve. It's very predictable. See, I show you here a case again to summarize this, a younger patient now, a patient I did with Professor Belzer. You see now here 4 video clips simultaneously. Also, you collect the blood and then the bone chips from the nasal spine or from the nasal fossa. You see a canine fossa, then we prepare the implant bed. See, and then the implant bed continues when there is a facial defect. As in most cases, we take the sharp edges off with a diamond, put the implant in a correct position, check the position, axis, everything must be correct. When this is done, then we do the BCM, we collect the blood to activate then the TBBM, and we apply the bone first, and then the bio second, and then the membrane. And the membrane goes in place in a 2-layer, or in a double-layer fashion to stabilize the membrane better, to be there as a temporary barrier function, and then a primary closure. Here you see the patient 8 weeks later for reopening, and here you see the patient at completion of treatment done by Professor Belzer. Fantastic, really fantastic aesthetic outcome. You see here the implant well integrated. We are still waiting for her to get a cone beam done, but now with this corona pandemic situation, we didn't have access to her in the moment. Okay, a last case in detail that just shows the whole potential. This was a case we did in 2008. You see, very difficult, huge defect, lots of bone, DBBM, membrane. You see, the whole bone was gone due to this long-lasting infection. Then everything was very nice, but then she developed a root resorption at the lateral incisor on the right side. So we had to take this off as well. Here you see the extended root resorption. Then we did a second early placement. See, it was almost a fully intact buccal wall. So here you see the patient 2016. So the first implant is 7 years in place, the other one 4 years. Everything nice, and I thought, I hope this tooth in between is not going to have a problem. 2 years later, she comes back, is in pain. You see, we had a chance to take a cone beam, and look here, this is where we have had this huge defect. This is now 9 years down the road. So we had to take this tooth off. It was elongated, huge periapical lesion, extended to the palatal side. So we took it off. And you see here then what we did. Of course, Professor Belzer took over, said we're going to have a 3-unit bridge. So we do extraction, socket grafting, ridge preservation, a soft tissue graft on top, and a provisional 3-unit bridge for the next 6 months. Here you see the provisional, and you see the radiograph with the provisional. See, and then finally Professor Belzer could do the final restoration. This is now the final restoration, 3-unit bridge. This implant is now 11 years in place, and this implant is 8 years in place. And you see beautiful maintenance of bone, in particular in this area where we did the ridge preservation technique. Here we did contour augmentation, here we did contour augmentation. So this is the patient smiling, also really a very attractive treatment outcome long term. So how is it documented? We have a couple of publications. 2 patient cohorts have been published up to 10 years. One with tissue level implants, one with bone level implants, both by Straman. Here you see one of the bone level cases of that study that was published at 10 years. You see all Professor Belzer, you see fully intact buccal wall, peak 1.5 millimeter coronal to the implant. This is the first patient I treated in 1998. There's a tissue level implant, look at the effect. And you see first time that we had this combination with collagen membrane primary closure. And here you see the patient 20 years later in 2018. See here now you see excellent tissue integration on the periapical, and here you see the patient in the cone beam. This is the buccal wall that is now fully intact for 20 years. Just a very good home care, of course, helps a lot. So the publication by Vivian Chapuis, published in Journal of Dental Research, only 20 patients could say, but all of them made it up to 10 years. So it's a prospective 10-year study. I only want to show you the radiograph here. That's the most important one. In about 70%, also 14 cases, full intact buccal wall and the peak coronal to the implant shoulder. 5 patients intact buccal wall, but a little bit of resorption here, 0.5 millimeter, 0.2 millimeter. And 1 implant patient did not have any buccal wall, so this is a failed case in terms of augmentation. So we said with a 95% success rate at 10 years documentation. So with that one, I would like to come to my conclusions. You see, when you treat this kind of patient, and we can discuss it now, you need to understand the tissue biology. And you need to understand these ridge alterations, bundle bone resorption. We will discuss that. When you do a socket grafting, you can reduce the amount of resorption, but you cannot stop the bundle bone resorption. You get still a little bit of flattening, but you don't get a complete atrophic situation as without this. Huh? So when we do then the implant treatment, you have different options. You should choose a treatment option that gives you predictable outcomes. Predictable outcomes, see, so you need to have a very detailed 3-dimensional understanding of the local anatomy. So cone beam for me is a must in these kind of cases. We are using early placement when there is a thin buccal wall or a damaged buccal wall. And then we take the tooth out, do nothing, let the soft tissue heal, go back in at 4, 6, or 8 weeks, and do then implant placement with simultaneous contour augmentation. The long-term results are excellent. This combination really is a winner for sure. You see autogenous bone chips accelerate bone formation, give these growth factors with BCM. BioOs gives the volume maintenance or volume stability, and therefore it's a low-risk procedure, that's for sure, and it's very predictable. So I think with that one I want to stop. I think with this diagram we can do the discussion with Mauricio, because my strong message is, as a clinician, you can use all 4 options. Depending on the situation, depending on the age, depending on the aesthetic demand, depending on risk factors, medical risk factors, you see, you choose one of the 4. And you see, as I said, I use about 5–7% immediate implants. I use about 10–15% late placements. I love to use it in elderly patients because then I can minimize then the surgical morbidity. And where it's really important, I go for early placement because there I know I get a very aesthetic result.
Okay, before we pass on to Hermann, I would like to refer to the next master course at University of Bern, where you can see these surgical techniques in full detail, because in a GBR master course, where we also talk about sinus floor elevation, we always show 5 or 6 live surgeries that gives you all the details of these surgical techniques. Very predictable treatment outcomes, excellent long-term stability. The course had to be postponed from June to November due to the corona pandemic, and the new date now is November 18 to 20 in Bern, Switzerland. Now I pass on to Hermann for the discussion.
It's very active, and people have a lot of questions. But I would like to start asking both of you, you know, for the audience, you have shown success in, you know, one technique and the other, but what is your advice for the audience when it comes to selecting the best approach? Is it obviously evidence-based? How much of a role play the experience of the clinician? Why don't we discuss with the audience this topic?
Yeah, okay, I would say these procedures, also immediate implant placement is still not well documented, because all the 5 longer term studies show quite a significant soft tissue complications. I refer to a 5-year paper by Cousin, 5-year published, I think 2018, with more than 40% of mucosal recessions. But I think that with the new techniques, the improved techniques, the results will be better because it's a stricter case selection. That is one point. And this has to be based on the anatomy, as also shown. And the second one, as you mentioned, is the experience of the clinician, also the talent of the clinician. So if you are doing only 20 implant cases a year, I would fully recommend to refrain from immediate implant placement. It's a very difficult procedure and you have to be very cautious. When you are an expert in terms of specialist, you have 100 patients a year, then you will have enough patients also to select immediate implants, and then you can build up the experience level to be successful with this demanding approach. So these are the 2 main factors for me.
Mauricio?
Yeah, German, let me start again, because I was checking the participants, and there are participants from everywhere in the world. So good morning, planet Earth. This is unbelievable. Really, really, really. I have never, ever in my life talked to so many people at the same time from different places. Really wonderful. Congratulations. Now,
this is because of the quality of the speakers, huh?
No, I don't know. The quality of, yes, maybe, and the organizers as well. So, I agree with Professor Buser. I think knowledge is the key. Many of these papers, when people were performing immediate implant installation, they didn't know what we know today.
Yeah.
I mean, they didn't define very well this alveolar socket, the alveolar process, the basal bone. There was no definition. So we start to place immediate implants in different anatomies. And the outcome is, as we saw in these papers from the past. And even when we do our papers today, you see when you fail and do the proper diagnosis, we fail, the outcome is unpredictable. So we need more knowledge. Knowledge is the key. I have to say something.
Yeah.
I'm not as experienced as Professor Buser, and I always say that he has a GPS in his hand. I have seen him performing surgery several times, and he is unbelievable. You know, you could blind him, and he will place the implant in the perfect position.
No, don't exaggerate here.
No, well. Now, I'm a normal human being. And honestly saying, today I would not dare to place an implant in the aesthetic zone without the help of a surgical guide that was produced with these softwares for planning. I tell you, every single case from premolar to premolar in the maxilla, I planned in the software, I produced a surgical guide according to my planning, and then I placed the implant. So I know that that anatomy that I have can house an implant imperfection. That's what I would advise to everyone to do.
Thank you, Mauricio. I'm going to be bringing in some questions from the audience that, and there is one that it's very particular because it happens in every Congress and every time I see these proposed as a viable technique that I think we need to discuss. And I know what your answer will be, but I'm going to read the question how it came. And the question is, when the buccal wall is intact and we do immediate placement, isn't soft tissue grafting enough to preserve it? Do we always need to place bone? And I think we need to address that point. I know, Mauricio, you alluded to that. So if you do an immediate placement and the buccal wall is intact, is soft tissue grafting enough to preserve that anatomical situation?
No, not to my knowledge. It's a very dangerous procedure. I mean, well, we can do it and hope. Well, let's suppose that we have a very wide gap. It's a molar. Let's talk about a molar, right? Mm-hmm. A molar. The distance between the buccal wall and the implant surface is very long. In this situation, that's fine. But come on, we're talking about, let's suppose that we are all talking about from K9 to K9. I mean, this is very dangerous. I would not advise that. If we talk about molars, that's fine, but not about the anterior teeth. Absolutely not.
I think it's the following, you see. When you have a thin buccal wall, fully intact, then this is mainly composed of bundle bone, and this is going to resorb. Huh? You cannot stop it. We have learned that from this famous guy from Brazil. Huh? And he showed it with his study today, because when he says there is a wide gap and he's doing internal grafting, then time will allow him that the bone forms inside this thin buccal wall, and then the buccal wall outside resorbs, but inside bone can form, and that gives him then the 2 millimeter buccal bone wall. If it's thick, then it will not resorb. I would always do flapless immediate implant placement, because that is the true benefit for the patient. Because to do flapless implant placement immediately with restoration, this is really extremely attractive to patients in terms of morbidity and patient comfort, but only if you don't buy in a complication later on. So therefore, I would stick to thick buccal walls, and then you do always internal grafting, because there is a comparative study by Stephen Chen more than 10 years ago that clearly showed a big difference. When it's thin, then of course you can do an internal grafting when it's a wide gap, and then you compensate the resorption outside with a connective tissue graft. But I get this argument, of course. I just saw Bob Levine said, yeah, but then we combine that. But then I tell Bob, then please publish a study on 5-year data. No, it should work. You see, this is the old story that we don't have good data on these approaches, because we have done this immediate implant placement for 30 years in the United States, and there is still a lack of sound, good long-term documentation. So this should be documented. I believe that with a careful selection of cases, you can get better results than all the studies with these complications from the consensus conferences where we analyze the literature. It will be better, but we need to provide the evidence for that, you see. And I know that Maurizio is always doing that, so let's hope. I'm still optimistic. That's the same with socket shield, you see. See, there was yesterday a big discussion with Sandeep Singh, you've seen, with the Sach Dental Academy. And then they presented socket shield. And then I asked, what tissue is formed? And then they said, yeah, this is in a prospective study. We soon after 1 year data published. I heard that answer already 5 years ago. See, soon it's published. You see, they promise us that these socket shield studies will come, but we are waiting to get these studies. I'm sure that's just how it should be. Evidence-based treatments is very important.
So true. So there is another question, and I think that's it's going to be interesting. I know I'm not making it easy, but I think these questions are relevant. So the question says, during early implant placement and during the reflection of a flap, how can we differentiate the difference between woven bone that should ideally stay in the socket and what is attached on the flap as a connective tissue?
Okay.
For me, no, this is not
for
possible.
both. Yeah, I want both of you. So
it's not possible. No, it's not possible.
And it's not important at all. Huh? So you open up, I clean out the socket, you prepare the implant bed and put the implant in. Before I do that, I take off the sharp edges of the buccal defect, so it's nicely bleeding and has no sharp edges, because sharp edges will get resolved because they have no blood supply. So, and therefore, that's not important if you take too much off or not. The defect is always on the buccal, and there you place your autogenous chips. On top of that, the VBBM and then the membrane. And therefore, that's not important.
Mauricio? Mauricio, are you still there?
He got disconnected.
It looks like he's connected. Well, we're gonna move to yeah. Are you there, Mauricio? We're having some connections problems with Brazil.
Yeah, here we had to stop the video because we got disconnected to Brazil. As I said, it was a really big pleasure for me to be part of this webinar with Mauricio, my dear friend from Brazil, and of course with German Gallucci, my dear friend from Boston, where I had the pleasure to spend 6 months on a sabbatical 4 years ago. So with that one, I think we come to a conclusion. We're going to continue with these kind of webinars in the future. We will have a series of webinars offered by the University of Bern, my group, and we will see when we start. I wish you all the best, stay safe, and talk to you soon.